Welcome to the deep dive. Today we're going to zero in on a pretty crucial topic for your revision, antiphospholipid syndrome, you might hear called APS.
Yeah, APS.
Basically, think of it like your immune system gets a bit confused, starts making these antibodies, and they make your blood, well, kind of sticky.
And usually sticky, and that, unfortunately, can lead to things like blood clots and also problems during pregnancy.
Exactly. So we've got a set of revision notes here, and our mission really is just to pull out the absolute must-know stuff about APS, stuff that's going to help you revise effectively.
We'll be hitting all the key areas from the notes, what it is, the causes, risks, how it actually works pathophysiology-wise.
What else? It could be the differentials, who tends to get it, how it shows up clinically.
And then, of course, diagnosis, treatment, what the likely outcome, the prognosis is, and potential complications.
So yeah, if you're looking to get a really solid handle on APS quickly and figure out what's genuinely important for exams like the MSRA, you're definitely in the right place. Let's break these notes down.
Okay, sounds good. So let's start right at the beginning. How do we actually define antiphospholipid syndrome?
Right. So at its heart, it's an autoimmune disorder. Your body mistakenly churns out these things called antiphospholipid antibodies, or APLs. And these APLs, they can then cause this increased tendency for blood clots, thrombosis. And also, sadly, they're linked to significant pregnancy issues.
Yeah, the key things to remember are that predisposition to clots, both venous and arterial clots.
Right, in veins and arteries.
Recurrent fetal loss. And sometimes you might also see a low platelet count, which we call thrombocytopenia.
Okay. It's important to know it can be primary or secondary, isn't it?
Absolutely. Primary APS just happens on its own. But secondary APS, that pops up alongside another autoimmune disease. And the most common culprit there is SLE.
Systemic lupus erythematosus. Yeah.
That's the one.
Here's something really interesting, kind of a clinical pearl from the notes. You sometimes see a prolonged APTT clotting test result.
Yeah, which sounds completely backwards. Right?
Totally. You've got a condition causing more clotting, but one of the clotting tests takes longer.
It's because the specific antibody, the lupus anticoagulant, actually interferes with the phospholipids used in the lab test itself. It's an in vitro artifact, essentially.
Ah, okay. So it messes with the test, not necessarily reflecting slower clotting in the body.
Exactly. So if you see that prolonged ATTT, but the clinical picture screams clotting risk, APS should definitely jump up your list of possibilities. It's a key clue.
A really useful, if paradoxical, pointer.
Yeah.
Okay, so that's the definition. What about the why? What actually causes APS, the etiology?
Well, that's the million-dollar question, really. The exact cause is still pretty much unknown.
Okay.
It seems likely it's a mix of things, probably some genetic susceptibility in certain people,
Right.
which then gets sort of triggered by environmental factors.
What kind of environmental triggers are we talking about? Any specifics?
Well, certain infections have been suggested as potential triggers. They might kickstart that APL antibody production in people who are already genetically predisposed.
Okay. And just circling back to SLE, having lupus definitely increases your risk of getting secondary APS then.
Oh, absolutely. That link is really well established. If you have SLE, or actually other autoimmune conditions too, your risk of developing secondary APS is significantly higher.
Got it. So SLE is a big one. What other risk factors should we be aware of, besides having SLE or maybe another autoimmune disease?
Well, a family history of autoimmune disease is relevant. We mentioned those environmental triggers like infections. And interestingly, some medications have also been linked to triggering APL antibody production in certain individuals.
Right. Okay, so we've got the definition, the slightly murky causes, the risk factors. Now let's get into the nitty-gritty, the pathophysiology. How does APS actually cause these problems in the body? This sounds like where it gets complex.
It does, yeah. The central players are those antiphospholipid antibodies, the APLs. Somehow they disrupt the body's normal clotting balance, leading to this state we call hypercoagulability, basically. The blood is just much more prone to clotting than it should be, and these antibodies might also directly damage the lining of blood vessels.
And it's not just one single mechanism causing all this trouble, is it?
No, not at all. It's complicated because while these antibodies are the defining feature, we're still not 100% sure if they directly cause all the symptoms in every case.
Okay.
I mean, think about it. Up to maybe 5% of perfectly healthy people can actually have these APL antibodies floating around.
Wow, really? Without any symptoms?
Yeah, without ever developing APS. So it's not just having the antibodies. Something else has to be going on in people who actually get the disease.
That's a really key point for context, isn't it? Don't just jump to conclusions based on the antibody test alone.
Exactly. In people who do develop APS, it seems like there are multiple different pathways contributing to that hypercoagulable state.
Like what?
Well, there's evidence the complement system gets activated that's part of your immune response. You can also get antibodies that target key proteins involved in regulating clotting.
Ah, like the natural brakes on clotting.
Precisely. Proteins like prothrombin, protein C, protein S, these normally help prevent excessive clotting, so antibodies against them kind of take the brakes off.
Okay, I see. So it's attacking the control mechanisms.
Yeah, basically throwing the whole finely tuned system out of whack. Plus, these APLs can also directly activate platelets, those little cells that form clots, and they can activate the endothelium, the cells lining the blood vessels, making them more likely to trigger clot formation or get damaged.
Wow.
And there's even some evidence they react with oxidized LDL, the bad cholesterol involved in artery hardening. So yeah, it's a complex picture, multiple hits contributing to the problem.
Right, it's definitely not straightforward.
Okay.
Okay, so given all that complexity and the varied ways it can present, if someone comes in with symptoms that could be APS, what else needs to be on the list? What's the differential diagnosis?
That's super important. Because the symptoms can overlap with so many things, the differential list can be pretty long if the main problem seems to be blood clots.
Right.
You've got to think about other things that cause hypercoagulability. Inherited thrombophilias, for instance. Certain cancers can increase clotting risk. And in women, you always have to consider things like oral contraceptives.
Okay. And if it's mainly presenting with pregnancy issues?
Then you absolutely have to rule out other common causes of recurrent miscarriage, things like genetic issues in the parents, problems with the structure of the uterus, other underlying health problems in the mother.
And you mentioned neurological symptoms earlier, like strokes.
Yeah, if someone's having recurrent strokes or TIAs, especially if they're young, you might think about things like multiple sclerosis, which can sometimes mimic those kinds of events. Though the mechanism is different, the presentation can overlap.
Gotcha. And obviously, we need to think about those associated conditions for secondary APS.
Exactly. As we said, SLE is top of the list, but also rheumatoid arthritis and other inflammatory or autoimmune conditions. It's also worth remembering that just finding APL antibodies doesn't automatically mean someone has APS.
Right. You said healthy people can have them.
Yeah, and they can also pop up transiently with infections or be associated with certain blood cancers or even some drug exposures. So you really need the clinical picture alongside the persistent positive labs.
Okay, that makes sense. You need the whole package.
So who actually gets APS? What's the epidemiology look like?
Well, in the UK, the estimate is around 40 cases per 100,000 people. It can hit any age, really, but it's definitely diagnosed more often in women, particularly during their childbearing years.
Which probably relates to the pregnancy complication aspect, right?
Exactly. That likely brings it to medical attention more often in that group.
And the SLE connection, how strong is that in terms of numbers?
Pretty strong. Around 30%, maybe a third, of people with SLE will test positive for APL antibodies.
Oh. But again, crucially, not all of them will actually develop the clinical syndrome of APS. And remember that 1 to 5% prevalence of APL antibodies in the general healthy population.
Yeah.
Interestingly, that tends to be a bit higher in older people.
Okay. Are there any particular ethnic groups more affected?
Studies suggest it might be more prevalent in people of Black ethnicity. The overall higher rate in women is probably tied to the fact that autoimmune diseases like SLE are just generally more common in women.
Right. And how significant is APS as a cause of things like clots or pregnancy loss overall?
It's actually quite significant. Estimates suggest APS might be behind something like 20% of recurrent clots in younger people.
Wow, 1 in 5.
Yeah, and maybe around 15% of recurrent miscarriages. So it's definitely a major player in those areas.
And you mentioned genetics earlier. Is there a strong family link sometimes?
There can be, yeah. Some cases seem to run in families, suggesting that genetic susceptibility, specific HLA types have been implicated, things like DR7, DR4, DQW7, DRW53, but it's complex.
Okay, so more common in women, potential genetic links, significant cause of clots, and pregnancy loss. Now, how does it actually look when someone has it? What are the key clinical features we should be watching out for?
Well, as we've hinted, it's incredibly varied. That's one of the challenges. But the classic triad, the big 3 signs are recurrent blood clots, venous or arterial, those pregnancy complications we keep mentioning, and thrombocytopenia, the low platelet count.
Are there other signs or symptoms that might give you a clue?
Definitely. Some people develop a skin finding called reticularis. It's this sort of purplish net-like pattern on the skin.
Oh, right. I've seen pictures of that.
Yeah. Also, that paradoxical prolonged APTT we discussed can be a clue from the lab tests. And in pregnant women, things like preeclampsia or developing pulmonary hypertension can be linked. And don't forget, it often exists alongside other autoimmune conditions.
So it really can touch almost any part of the body then.
Pretty much. You've got the cardiovascular system with clots, obstetrics with pregnancy issues, hematology with platelets, skin with livedo, neurology with strokes. It can affect joints, kidneys, lungs, heart valves.
So specific examples might be things like stroke or that livedo pattern, or even problems with heart valves.
Exactly. Cerebrovascular events are common, the livedo reticularis. And yes, cardiac valve disease is another recognized feature.
Okay, let's unpack this. The sheer range is huge.
Yeah.
It really underlines why you need to consider it, even if the symptoms seem unrelated at first glance.
Absolutely. Which leads us perfectly into investigations. How do we actually pin down the diagnosis?
Well, the absolute cornerstone is testing for those specific antiphospholipid antibodies we talked about.
Right, the big three.
Yep. Lupus anticoagulant, anticardiolipin antibodies, and anti-beta-2 glycoprotein-1 antibodies. And then, of course, you might use imaging or other blood tests to see if there's been any organ damage or to check the overall clotting system.
Precisely. And for a formal diagnosis, we use specific criteria. You generally need at least one clinical criterion and one laboratory criterion met.
Okay, let's break that down for revision. What counts as a clinical criterion?
So on the clinical side, it's either 1, vascular thrombosis, basically a confirmed clot in any artery, vein, or small vessel. Or 2, pregnancy morbidity.
And pregnancy morbidity includes a few specific things, right?
Yes. It includes 1 or more unexplained deaths of a seemingly normal fetus at or after 10 weeks gestation, or 1 or more premature birth before 34 weeks because of severe preeclampsia or placental insufficiency, or 3 or more unexplained consecutive pregnancy losses before 10 weeks.
Okay, so thrombosis or specific pregnancy problems.
Yeah.
And the lab criteria.
For the lab side, you need a positive test for one of those 3 antibodies we keep mentioning. Lupus anticoagulant or medium-high levels of anticardiolipin antibody or elevated anti-beta-2 glycoprotein IgA antibody, usually above the 99th percentile.
And
Crucially, that positive test needs to be confirmed. It has to be positive on 2 separate occasions, at least 12 weeks apart.
that 12-week interval is key, isn't it? Why wait so long?
It's really to make sure the antibody positivity is persistent. Sometimes these antibodies can pop up temporarily, maybe after an infection or something. Waiting 12 weeks helps rule out those transient cases and confirms it's an ongoing issue, which is more characteristic of APS.
Makes sense. Are there specific groups of patients where screening for these antibodies is generally recommended?
Yeah, guidelines often suggest screening in younger adults, say under 50, who've had an unexplained stroke or TIA, and also in women who've experienced that pattern of 3 or more early miscarriages before 10 weeks.
Okay. And besides the specific antibody tests, what else might you check?
Well, a full blood count and FBC is important. That's where you'd spot the thrombocytopenia or maybe signs of hemolytic anemia. A basic clotting screen gives you the APTT and PTINR. Imaging like CT or MRI might be needed to look for evidence of clots or organ damage.
And maybe Doppler ultrasound for DVTs.
Exactly, Doppler for DVTs.
Okay.
And an echocardiogram, an echo, is useful to check the heart valves and look for pulmonary hypertension.
Right. Memory tip time. So for the labs, remember LAA, ACA, AVG1, lupus anticoagulant, anticardiolipin, anti-beta-2, glycoprotein-1, and don't forget that 12-week repeat.
Perfect. That's a great way to remember the key tests.
Okay, so we've diagnosed it. How do we manage APS? What's the general game plan?
Management really revolves around preventing clots, managing pregnancy safely, and dealing with any other symptoms or associated conditions. A lot of the guidance comes from organizations like Euler.
What if someone has the antibodies, but they've never actually had a clot? Do they need treatment?
That's primary prophylaxis. In someone with persistent APL antibodies but no history of clots or relevant pregnancy issues, often low-dose aspirin is recommended to reduce the risk of a first clot.
Okay, and if they have had a clot, secondary prophylaxis?
Yes. After a venous clot, like a DVT or PE, the standard is usually lifelong anticoagulation with warfarin.
Warfarin, okay. What's the target INR range?
Typically aiming for an INR of 2 to 3. If someone has another clot while on warfarin in that range, then doctors might consider adding low-dose aspirin as well, or even aiming for a higher INR target, maybe 3 to 4.
And for arterial clots, like a stroke?
Similar approach, usually lifelong warfarin, aiming for that INR of 2 to 3. It's worth noting that the newer anticoagulants, the NOACs or DOACs, are generally not recommended as first line for APS based on current evidence.
Right, so warfarin is still the go-to. And what if someone on warfarin wants to get pregnant?
Good point. Warfarin isn't safe in pregnancy, so they'd need to switch to heparin injections, usually low molecular weight heparin, typically before conception or as soon as pregnancy is confirmed.
Got it. What about general advice, lifestyle stuff?
Oh, absolutely crucial. All the standard healthy lifestyle advice applies, and maybe even more so. Definitely no smoking. Regular exercise, healthy diet, maintain a healthy weight, limit alcohol, and tightly control any other risk factors like high blood pressure, diabetes, or high cholesterol.
Makes sense. And if someone has an acute clot right now?
You treat the acute clot itself using standard protocols, often starting with heparin and then transitioning to long-term warfarin as we discussed for secondary prevention. If clots keep happening despite being on warfarin, you'd need to investigate further. Are they taking it properly? Is the INR truly therapeutic, or is something else going on?
Okay. And pregnancy management, you said, is critical. What does that usually involve for someone with confirmed APS and maybe a history of loss?
Yeah, for women with APS who've had recurrent losses, the standard treatment during pregnancy is usually a combination of low-dose aspirin plus daily heparin injections. This significantly improves the chances of a successful pregnancy.
Okay. And what if they have the antibodies? Maybe a history of preeclampsia, but not the full recurrent loss picture.
In those cases, sometimes low-dose aspirin alone might be used during pregnancy. And importantly, because the risk of clotting is also higher after delivery, postpartum thromboprophylaxis with heparin is often considered for women with APL antibodies, even if they didn't need it during the pregnancy itself.
Right, that postpartum period is high risk. So with all this treatment, what's the outlook? What's the prognosis generally like for someone with APS?
It really varies. It depends a lot on which organs have been affected, how severe it is, and if they have other conditions like SLE alongside it. But the good news is, with proper diagnosis and consistent management, especially long-term anticoagulation, many people can live pretty normal lives. However, it's definitely a serious condition. If it's not well managed, it can lead to major problems: PE, stroke, heart attack, chronic lung problems from clots.
Yeah, which brings us neatly to the complications. We've mentioned the big ones, but let's just summarize the key risks.
Okay, so number one is recurrent blood clots manifesting as DVTs, PE, strokes, heart attacks. Number two is those pregnancy complications, miscarriages, stillbirths, preterm birth, preeclampsia. And thrombocytopenia itself can sometimes be severe enough to cause bleeding issues, although clotting is usually the bigger problem.
And you mentioned some less common but really serious things earlier.
Yeah, here's where it gets really interesting, or rather quite scary. You can get cerebrovascular events, strokes, TIAs, sometimes linked potentially to Liebman-Sachs endocarditis, which is inflammation on the heart valves seen sometimes in SLE and APS.
Right.
Heart attacks, myocardial infarctions can happen even in young people with APS. You can get significant cardiac valve disease, sometimes needing surgery, which can also lead to severe pulmonary hypertension.
And the really rare severe one.
That's catastrophic APS, or CAPS. Thankfully very rare, less than 1% of patients. But it's devastating, widespread, small clots, causing multiple organs to fail rapidly over days or weeks. It's a medical emergency requiring intensive care.
Wow. Okay, so definitely a condition with a wide spectrum of severity and potential complications.
Absolutely.
So wrapping up our deep dive on APS today, it's clearly a complex autoimmune condition. Those antiphospholipid antibodies are the key, leading to that sticky blood state with major risks for clotting in pregnancy.
Yeah, and getting the diagnosis right, using both the clinical picture and those specific lab tests, remembering the 12-week repeat is just vital. And understanding that for many, lifelong management, usually with anticoagulation, is going to be necessary.
Definitely. It really highlights the importance of recognizing the varied ways it can show up and managing it proactively. So here's a final thought to mull over. Considering how varied APS can be and how serious it can get, how might earlier recognition and better ways to stratify risk truly change outcomes for these patients down the line?
That's a great question, something researchers are actively working on. Better biomarkers, better risk prediction tools.
Yeah. Well, if you're revising for your MSRA exams and want more high-yield resources like this, definitely check out passthemsra.com.
And also freemsra.com for loads of free questions and guides.
Brilliant. Thanks so much for joining us today to dive deep into antiphospholipid syndrome.